All right, let's talk about systemic lupus erythematosus, or SLE. This is one of those really complex conditions we see, and as pharmacists, our role is huge. So, over the next few minutes, we're going to break down the key therapies and, maybe more importantly, the counseling points that can really make a difference for your patients. So, here's what we've got on cap. We'll kick things off with the challenge of lupus itself, then jump into foundational counseling. After that, we'll tackle severe disease, look at the newer biologics, and then a really big one, special populations. We'll wrap it all up with some key takeaways you can use right away. Okay, first up, the lupus challenge. Before we can talk about treating it, we've got to understand what we're really dealing with here. And trust me, it's a unique beast. So what is SLE? Well, you can think of it as a case of friendly fire. The body's immune system, which is supposed to be your personal security guard, gets confused. It starts attacking your own healthy tissues instead of just germs and viruses. This creates these things called autoantibodies, and they can cause inflammation and damage pretty much anywhere: skin, joints, kidneys, you name it. And you might be surprised how often you'll see this. We're talking about 1 in every 1,000 or 2,000 people. And here's the kicker: it mostly affects young women, right in their reproductive years. So you can see why those conversations about family planning aren't just a nice to have. They are absolutely essential for us to lead. So what are we trying to achieve with treatment? It's not just about putting out fires when symptoms flare up. No, we're playing the long game here. We want to stop organ damage before it starts, give patients their quality of life back, and this is a huge one, get them on the lowest possible dose of corticosteroids or even off them completely. That's the real goal. All right, let's get into the nitty-gritty. This is where we build the base of therapy and counseling. Okay, before we even touch a prescription pad, we've got to talk about the non-drug stuff. And this is all on us to counsel. Sun exposure is a massive trigger for lupus flares, so sunscreen, SPF 30 or higher, is non-negotiable. Same goes for smoking. It's gotta stop. And here's a huge safety point: immunizations. You have got to check their vaccine status before they start any immunosuppressants, because once they're on them, live vaccines are off the table. Get those done up front. Now, let's talk about the true cornerstone of SLE therapy: hydroxychloroquine. Just about every patient with lupus should be on this. Why? Well, yeah, it helps with things like joint pain and fatigue, but that's not its superpower. Its real magic is that it's been shown to prevent organ damage from piling up over the years. That makes adherence absolutely critical. But, and this is a big but, with hydroxychloroquine comes one major counseling point you cannot miss: retinal toxicity. It's rare, sure, but it's also irreversible. So we need to be crystal clear. The dose is capped at 5 milligrams per kilogram of actual body weight per day. No exceptions. And they absolutely must get a baseline eye exam before starting, and then regular checkups with an ophthalmologist. This is a non-negotiable part of the therapy. Okay, so what happens when things get more serious? When the disease really flares up? Well, that's when we have to escalate care. This is where corticosteroids come in. And you know the deal. They're a classic double-edged sword. They are fantastic at stamping out a severe flare, and fast. But the long-term side effects? They're a real problem. We're talking osteoporosis, weight gain, diabetes, hypertension. The list goes on. So the mission is always to get the patient to the lowest possible dose as quickly as possible. Our job is to be the watchdog for these side effects. And that brings us to the steroid-sparing agents. And this is where our counseling can genuinely change someone's life. Look at these two options for severe lupus nephritis: mycophenolate versus cyclophosphamide. The key difference? Fertility. Mycophenolate is preferred for anyone who might want to have children down the line. Cyclophosphamide, on the other hand, can cause permanent infertility. That's a conversation that has to happen up front, and it has to be handled with incredible care. All right, moving on to the newer frontier: biologics and targeted therapies. This is where things are getting really interesting and offering new hope for patients. So let's look at a couple of the big players here. First, you've got belimumab. It targets B cells, so your main counseling points are going to be about watching for infusion reactions and, of course, any signs of infection. Then there's erythematosus, which works on a totally different pathway, the interferon receptor. The big red flag with this one is an increased risk of shingles. So what's the pharmacist's move? Make sure they get that shingles vaccine before they start. Super important. Okay, let's talk about what might be one of our most critical roles: counseling on pregnancy and breastfeeding. Remember who this disease primarily affects? Young women. So this conversation isn't a maybe, it's a must. And planning before conception is everything. So many of these drugs are teratogenic, meaning they cause birth defects. They have to be stopped, and not just the day someone wants to start trying. Look at these timelines. They are not suggestions. Methotrexate, stop it 3 months before. Mycophenolate, 6 weeks. And then there's leflunomide, the really tricky one. You either stop it 2 years in advance, or you do a special washout.
And about that washout, it's a pretty intense process. For anyone on leflunomide who doesn't want to wait 2 years, we can do this. You basically give them cholestyramine or activated charcoal for 11 days to actively pull the drug out of their system. But you're not done there. You have to verify with 2 separate blood tests that the drug level is undetectable. It's a protocol we should all know about.
Okay, so this is your go-to guide. Which meds are safe during pregnancy and breastfeeding, and which are an absolute no? The good news is that some of the most important ones, like hydroxychloroquine and low-dose prednisone, are generally okay to continue. And that's fantastic because stopping them could risk a flare, which is the last thing you want during a pregnancy.
All right, let's bring it all home. What are the key things you need to have in your back pocket for your practice?
Okay, think about this. Our patients are avoiding the sun, which means less vitamin D. And many of them are on steroids. That's a 1-2 punch for their bones. So we have to be proactive about counseling on calcium and vitamin D. And if your patient is on 7.5 milligrams of prednisone or more a day, that's your trigger to make sure they're getting screened for osteoporosis risk. So if you take away nothing else, let it be this checklist. 1. Hydroxychloroquine is foundational, but always counsel on the eye exams. 2. Steroids are a temporary fix, not a long-term plan. The goal is always to reduce them. 3. Check that vaccine history before starting immunosuppressants. 4. Look beyond the lupus. Manage their heart and bone health proactively. And 5, probably the most important, always talk about contraception and family planning. So I'll leave you with this question to think about for your own practice. How can you build these checks into your workflow? Is it a pop-up alert in your computer system? A dedicated checklist for every new lupus patient? Think about what you can do tomorrow to make sure these patients, who are dealing with so much, get the absolute best and safest care from you.